Hello. Yes. Welcome to the PMNET. My name is Valaine. I'm a pediatric hemato-oncologist, and I have the honor to open this session, which is dedicated to pediatric oncology. Pediatric oncology is a disease which is the leading cause of non-accidental death in children and adolescents still. Even though in the last 50 years there has been huge development, and thanks to novel therapies and development and improvement of supportive care, there is also an improvement of long-term survival. However, for the reason of long-term sequelae and the toxicity of treatment, there is still significant morbidity in the long-term survivors. And for patients with relapsed disease, the outcome remains poor. And this is why precision medicine and using the knowledge of disease biology and genetics is even more important to even more improve and help to improve the survival and promote the best quality of life to our patients that we can. In this session, we have 4 wonderful speakers. And I have the honor to introduce the first of them, Professor Stefan Pfister. Professor Stefan Pfister is the director in Preclinical program Hopp Children's Cancer Center in Heidelberg. He's the head of the division of Pediatric Neurooncology at the German Center of Research, and he also coordinates the INFORM program, which stands for Individualized Therapy for Relapsed Malignancies in Childhood. And Professor Pfister is going to explore the embryonal origins of pediatric cancers and how this could be translationally exploited. Please, Professor.
Shall I take this one?
I think so.
Supposed to be on? Can you hear me? Yeah. Okay, perfect. Yeah, thanks a lot, Anna, for the kind introduction. Sorry, it's me again. I will be talking about a completely different topic and also about stuff that is kind of unpublished or conceptual since we are amongst ourselves as pediatric oncologists now. And I hope that this will be also generating some discussion. So I ended with my last talk by asking the question, will we ever be able to think about secondary prevention for pediatric cancer? And I guess why I'm saying this is that this will really be a challenge, because all of what has been traditionally thought to be preventionally causes of cancer, such as smoking, obesity, pathogens, overweight, whatever, sun exposure, drinking, and so on, is not relevant to the pathogenesis of pediatric tumors. The only thing we know is actually that 10 to 15% maybe of them are inherited. But apart from this population, the question is, how could we diagnose them much earlier, or could we diagnose them much earlier, maybe in a premalignant state or in a very early state where they are not metastatic yet. And I think we can probably conceptually think about pediatric tumors as very often a developmental disease where actually normal development is hijacked by certain genetic aberrations that are happening that lead to a maturation block in a primitive cell population, and then to the outgrowth of a tumor, which is, again, in complete difference to most of the carcinomas in adults, where the continuous accumulation of mutations over a long period of time, mostly through mutagen exposure, is actually leading to cancer. So I think when you think about this, you would conceptually say, well, maybe then we also have to look into the origins of pediatric tumors a little bit more closely. And one of the first hints that we got, which was a bit, I think, buried in a large paper about the first cancer genome sequencing data in medulloblastoma that we had published like more than 10 years ago, one of the most puzzling findings was that actually the majority of group 3 and group 4 medulloblastomas, which you probably know, are making up a big proportion of all medulloblastomas, actually seem to have no single mutation with an allele frequency that is close to clonal, which essentially means that in many of these cases, actually the tetraploidization or the aneuploidization of the genome is supposedly the first genetic hit that is happening. And we all don't really like that because we don't really know how to pinpoint individual genes to drive tumors. We also don't like to study large copy number aberrations that are recurrently happening in all the pediatric tumors because we have upregulation of hundreds of genes and downregulation of hundreds of genes, and it's very hard to interpret that. But it's just a matter of fact that they seem to be occurring very early. When we now collected our first larger data set on single-cell transcriptome and ATAC-seq data on these group 3 and group 4 medulloblastomas, we intentionally focused on a cohort that was only comprised of tumors from group 3 and group 4 medulloblastoma that had a MYC amplification, a MYC-N amplification, or PRDM6 aberration to make sure that we actually include samples where we think we know what the driver was. So we generated single nuclei data from a few 100,000 cells representing all of the different subtypes of group 3 and group 4 medulloblastoma from these 3 genotypes, as we probably would call them. And one thing, kind of methodological development that turned out to be very useful is that copy number calling from RNA sequencing, single-cell RNA sequencing data is notoriously difficult. I think many of you have probably used or heard about infer-CNV, which is one of the tools that everyone uses to infer copy number aberrations from single-cell RNA sequencing data. And it turns out that the ATAC sequencing data are much more robust in terms of calling copy number aberrations from the single cells. So what you can actually do in this case, for instance, is actually use the single-cell ATAC data to also look into clonality of genetic events at a copy number level, in this case an NMYC amplification in a subclone of this medulloblastoma. We looked into this more systematically in this cohort and actually figured that in none of the tumors that we thought was driven by an NMYC amplification, the NMYC amplification is actually a clonal event, indicating that possibly this is not the initiating event. Otherwise, a proportion of tumor cells must have lost it during tumor evolution. And this is also evidenced further by the fact that all of them have clonal large-scale copy number aberrations that must have happened before the NMYC amplification has happened. When you look into MYC amplifications, the same picture. They are all subclonal. One of them, we had a single example where the MYC amplification was clonal, but all the others are actually subclonal. And which is, again, something really interesting, we found a sample where part of the tumor had a MYC amplification and another part had a MYC-N amplification, which we always thought was not compatible. And I think that there's no other indication or entity, even in the adult world, where this was ever described. So what we concluded from this is that actually it looks as if these oncogenic hits that we thought were the driver of these tumors are typically subclonal, typically occur after large-scale copy number aberration. And there's a very nice paper that probably many of you have seen that was published last year in looking at a very similar thing in neuroblastoma, where they actually found a very similar pattern in neuroblastoma that very often these copy number aberrations, aneuploidization seems to be the first genetic hit, and they even basically showed for the first time using population genetics and mathematical modeling that most possibly these large-scale copy number aberrations happen during even the first trimester of pregnancy. That was the first hint that if this is really true, that we might also be able at some stage to detect these clones, whatever they are, pre-malignant or malignant much earlier. And this is actually using bulk whole genome sequencing data where on the one hand the allele frequencies and on the other hand the copy number, the altitude of the copy number aberrations are actually utilized to predict for the individual genetic hits their timing and how many population doublings happened since this genetic event has happened. And based on this, we could actually show two interesting things. One of them is that the tumors that have a MYC or MYC-N amplification or PRDM6 aberration actually seem to be occurring relatively late. So they basically are not the ones that have the earliest origin, which argues in favor of this of a need, of a bottleneck need for this oncogenic hit to be acquired for the tumor to really get into exponential growth. And the second thing was when also using these prediction methods from population genetics, that in most of the cases of group 3, group 4 medulloblastoma, we would also predict that these early genetic events, copy number events, actually happen before or shortly after birth. So this is why we think that these events that we see, like the MYC amplifications, the MYC-N amplifications, are very important for tumor progression, but not important or not even involved in tumor initiation, which is also interesting when you think about mouse models, for instance, because we are generating mouse models using MYC and P53 and think now we have a perfect group 3 model. But this is not how the group 3 tumors in children may occur. Another end of the spectrum is looking at relapse or end-stage disease. And there, in the few cases that we had serial samples, we could actually see that the MYC amplification becomes clonal. So it's not present at the time of tumor initiation, but it's clonal and the dominant driver at the time of progression of the tumor. So our model to date is that large CNVs seem to initiate these tumors typically before birth, that these oncogenic drivers are needed for tumor maintenance and progression, but not for tumor initiation. By the time of birth, many tumors should be sizable according to this mathematical modeling. And one thing that I couldn't show today for time reasons, but one thing that we also looked at is the spatial distribution of these aberrations. And you would think that if, in one subclone of the tumor an aberration happens, like a MYC amplification, that there's also a regional outgrowth of this clone in one part of the tumor. But as a matter of fact, in most of the cases, it's completely intermixed. So there must be some sort of a migratory process happening that is actually mixing MYC-amplified and non-amplified tumor cells that seem to form some sort of an environment that is beneficial for both the MYC-amplified and the non-amplified cells. So we see that the MYC clone is getting selected under treatment pressure. And we have submitted this, so you can also read it if you're interested in bioRxiv. But the question now really is, what can we do with this? And so since we see this pattern of these copy number aberrations happening early on, since we have established very sensitive tools by now from minute amounts of circulating DNA, to actually detect both methylation profiles and copy number aberrations, it's plausible that by now we can actually screen or start thinking of screening blood from children that were never diagnosed with a tumor to see whether we can find these copy number aberrations that might be specific to certain tumor types, but also match the cellular origin of these aberrations by the methylation profile that we can read out. And so what we are currently starting, and that's just kind of a look into the future, and I don't have any data to present, but we basically do about 20% of the German newborn screening, so the metabolic newborn screening in Heidelberg, and we have matched the cohort that they have assembled over the last 10 years with the childhood cancer registry and identified more than 1,000 patients with solid tumors, not only brain tumors, also non-brain tumors, who actually have developed a tumor during the first 10 years of life, and where we have the Guthrie card available still to look whether we could have detected something in these Guthrie cards earlier, and we are matching this to some normal populations. And maybe in 3 years we come back and say we have found nothing, but it's plausible from the data that is out there now that at some stage it might be possible, and the methods might be sensitive and specific enough to actually detect these early aberrations, which then would lead us into potentially an era of secondary prevention, because then we could basically put these patients at risk on surveillance programs and don't have to wait for a symptomatic and probably metastatic tumors very often to happen, and then we are running behind this. So with this, I'm stopping, not going over time this time, and thanks a lot for your attention, and again, warmly invited to visit us in Heidelberg. Thank you.
Thank you, Professor Pfister, for this very, very interesting talk. I never thought that we would come so close so soon to having a potential screening for childhood cancer. Maybe there is a question. Now we have time for one question, if there is such. Please.
That's super. This is super interesting, but also super interesting will be a potential result that you may get, like in childhood leukemia, 10 or 100 times more. In childhood leukemia, it's 100 times more. Prenatal, not prenatal, early post, the first event. So that's from the Guthrie card. And also, it's the same question. You know, have you thought to check brains from abortions, which will be it will be very challenging, but maybe extremely well informing.
Yeah, all very valid questions. So starting with the second question first, so we have started to do this. In fact, there are also some biorepositories where material is available. The problem there is the numbers, right? Because if you think of this as conceptually about clonal organopoiesis in parallel to clonal hematopoiesis, it's probably happening in every organ, in every cell type to a certain degree. And you have to really have a very good overview on what is kind of physiological and will never transform. And this is also kind of addressing your first question. I think that we basically have to first get a good handle on, you know, the likelihood of a certain constellation to transform malignantly. I mean, the first TEL-AML fusion was also detected on a Guthrie card, by the way. So I think that this is not something conceptually completely new, but it was never considered in solid organs. And I think, based on the fact that these copy number patterns that we find in the tumors are highly, highly recurrent and specific for certain tumor types, it's plausible that based on the precise cellular origin and the precise constellation of the copy number aberrations, it will be possible to predict the likelihood of this becoming malignant at some stage. But again, this is a hypothesis at this stage.
Thank you. I think we need to move on. We will have a Q&A session at the end. So I welcome you to ask questions and keep them for the end. And now I have the honor to introduce our next speaker, Professor Shai Izraeli. Professor Shai Izraeli is from the Pediatric Hematology department at the Schneider Children's Medical Center in Tel Aviv. And today's talk will be dedicated to precision medicine in pediatric hemato-oncology.
So I thought that instead of focusing on a specific topic, giving specific results, to give kind of an overview, and giving you actually 3 examples for the way we use in our center precision medicine for pediatric oncology. And Stefan already gave half of my talk in the first the plenary. So I will use it as an introduction. So So that's how every place that does precision oncology need to be organized. You need to have a genome center, or I would say diagnostic center. Now we talk about genomes. I have no doubt, well, I don't know, but I think that there will be proteomics will come to the omics center. So diagnostic centers, and you need to have really a clinical trial center where you can translate these results. So I will give 3 examples. I'll give a few comments on 3 topics. One is using precision medicine for targeted therapy. The second one for diagnosis and classification of brain tumors. That's where Stefan was so kind to introduce. And then I want to talk about so-called benign hematology that is not so benign. So, of course, targeted therapy is this drug for you, and I was, now it's again the Nobel Prize season, and I'm still, you know, people are dying. Some of them are already dead. I don't know if Noel is dead. One is already dead, but this should have received, this really should have received a Nobel Prize. It's everything that goes around BCR-ABL, from the identification of the translocation till the development of imatinib, and it was the prototype for targeted therapy, right? The effect of ABL inhibitors for CML and ALL with Philadelphia positive. But since then we have many targeted RAB. You mentioned one of them, BRAF inhibitors, for many other diseases, but perhaps the advance that is most similar to imatinib, although may be relevant to less patient, is the one that is represented by this patient that came to us 5 years ago with infantile fibrosarcoma that did not respond to chemotherapy, and then our diagnostic center, so that's why you have to have a diagnostic centers, gave us the result that he has an NTRK3 fusion, and this is the time when the really first clinical trials with specific NTRK inhibitors were opened. This one received this drug in collaboration between our center, in between our center and the Heidelberg, where they was one of the very few centers that runs this therapy with a drug that is called now larotrectinib. At that time it was Loxo something. But what was amazing, and absolutely amazing, and is amazing, is the response to the drug. So here you see before therapy, this is oral syrup, right? So this is 2 weeks after. This is 8 weeks after. At that time, he underwent surgery. We found no tumor cells whatsoever. This was really unbelievable. And this is a more recent patient that we treated in our center, already in our clinical trial unit. So this is after biopsy, 3 days of therapy, 1 week of therapy, 2 weeks, 6 weeks, and 11 weeks. I haven't seen any targeted therapy that is more effective in a shorter time. And coming back to the first slide, so this patient is a patient that had glioma at the time. This is, I think, 12 years ago, something like this, or 14 years ago. And this is actually a lab employee that his hobby is origami. You see here, origami, and he sits with the patients. And she, as Stefan showed, she got actually cured from her low-grade glioma, but only when they were in Canada. The family was representative of Israel, something in Canada 2 years ago. She was 14, and she was diagnosed again with brain tumor. My guess, I don't know the details, so my guess this was a secondary tumor rather than a relapse of the tumor that she had when she was 2, and luckily enough, she has NTRK fusion, and she is now in complete remission. So this is really, this NTRK targeting drug is amazing. So from the euphoria, let's land into reality. This represents the real problem of targeted therapy, and the real challenge of targeted therapy is the story that I'm telling you here. So this is, we have identified JAK2 mutations in leukemias, ALLs of Down syndrome. We have long time interest in Down syndrome, and very quickly this has been shown to be a marker of a subgroup of pediatric leukemia that is called Philadelphia-like leukemia, because the signature is similar to BCR-ABL, but actually the majority of these leukemias do not have ABL or ABL type translocation, but have a JAK type, JAK-STAT activating mutations. So what would have been very natural is to treat everybody with JAK inhibitors, right? And there are JAK2 and JAK1 inhibitors. Ruxolitinib is the prototype of these. So that's became a really, perfect idea. But we have casted some questions about this idea, because we have decided to study specimens, a diagnosis and relapse of these Philadelphia JAK-driven Philadelphia-like leukemias. And what we found that the JAK2, like the MYC in medulloblastoma, because right there is a medulloblastoma subtype that is called MYC. And then you find MYC is not the clonal event. And we found that JAK2 is not the clonal event, even it's the VAF, variant allelic frequency, is very high, but it's actually subclonal. And the JAK2 clones are very sensitive to chemotherapy. So here you see a very typical patient. So this is a patient that had 3 relapses, diagnosis, and then 2 relapses. And you see the JAK mutated clone was extremely prevalent. Diagnosis, this patient received only chemotherapy, the JAK mutated clone disappeared, and then instead appeared 2 other subclones. One with RAS, this is the major clone, and one with a JAK1 mutation, and the patient received chemotherapy, and they disappeared. And then another subclone with another RAS mutation appeared. So that's represent the major problem of targeted therapy. So there is a lot of hype around targeted therapy. Everybody is sending foundation medicine, etc., etc. This sometimes change therapy, but rarely actually change the outcome of a patient, except for very rare and very typical disorders. So that's about targeted therapy. The second actually, Stefan made my life easy for me. I don't need to go into the background of brain tumors. But I want to show, you mentioned it in kind of a last slide, to show what can we do with a novel technique that is called nanopore sequencing for diagnosis of a brain tumor. So this I can move, this is the work of these two very talented postdocs, and it's right now in a review, and they adapted nanopore for diagnosis of FFPE samples. Nanopore, for reasons that we cannot go into now, is usually used for fresh frozen tumors. So brain tumors, we talked about the necessary for tumor classification, what is methylation, and the Heidelberg classification. So now this is generally used. But the tool that is generally used for it are Illumina microarray, and the methylation allow us to show that not everyone that is alike is really alike. The Illumina, however, necessitate, and that's very relevant when we talk about spreading technology. Illumina necessitates a huge lab. That's one problem. The second problem, that it necessitates a chemical reaction, bisulfite reaction, in order to identify the methylation. Again, we won't go into it. Why do you need it? So you need a very complex wet lab procedure, a high DNA input amount that is difficult from FFPE samples, and it costs a lot and it takes a lot of time. So can we do it better? And here comes nanopore sequencing. So nanopore is not only the size of the pore through which the DNA passes, but all the instrument is really very small and reminds a disk on key, a flash drive. and the DNA goes through the pore, and here electric current is measured. The response to electric current is measured, and the response to electric current really depends on the chemical structure. So each nucleotide, there is a different response. This is the way you can really sequence the DNA, and therefore it's easy to detect methylation without any other, you don't need to do bisulfite conversion or anything like this, because a methylated nucleotide absorbed current differently than a non-methylated nucleotide. So it's really actually very easy to diagnose methylation. This is usually done on fresh frozen samples. The one disadvantage, and kind of, you mentioned it kind of on the way, of a fresh frozen samples is, for example, you don't know what is the percentage of tumor. Sometimes it's a normal tissue, and also, in addition to this, again, not everywhere fresh frozen samples are available. So we've adapted it to FFPE. I won't go into all the technical issues. I just want to give you two examples, amazing examples, and we are keeping having these examples. So this is a child that presented what looked like a very high grade tumor. At least it behaves in this way clinically, and there were all kind of potential diagnoses. Neuropathologists could not identify this tumor. Methylation sequencing by nanopore identified, to our huge surprise, as meningioma, and only, and that's also what Stefan described, only we went back to pathology and told them, look, this looks like meningioma. They approved it by a proper staining, etc., because they didn't use even this staining because, you know, it wasn't logical that this type of tumor will be meningioma. And the next example passed me to also the next topic. This is a child which was delivered preterm because of this urinoma. So you see that there is an arrest of urine in the bladder, and sure enough, a tumor in his spine was diagnosed. And what is the most common tumor at that stage? A neuroblastoma. From the biopsy, even pathology was not available. The amount was so small and so inappropriate that even pathology was not available. So the working decision was, this is neuroblastoma, let's start treat the child as neuroblastoma. But we subject the little DNA that we had just 20-something nanogram of DNA from FFPE. We subject this to a nanopore sequencing, and we got a complete different diagnosis. We got the diagnosis of ATRT, atypical rhabdoid tumor. Now, the importance here is not only that it's a different therapy because the child died anyway. I mean, ATRT at this stage is fatal, but it's important from cancer genetics because ATRT at this stage is hereditary. And therefore, for family planning, etc., it was very important. So to summarize this part, this allows the nanopore sequencing allow early, rapid, and accurate classification. Also during surgery, so results can be available less than 2 hours. So if there are questions during surgery, whether to go to a complete resection or not to complete resection, low-grade glioma, do not need complete resection, then it's very useful, and it guides decision making in challenging cases. And I want to use the next. I want to overgo 1 minute on my time to show you another way we routinely apply precision medicine, and this is the diagnosis of bone marrow failure. So this we published not so long ago. Every child with persistent cytopenia that is not ITP, okay, no chronic ITP, but every child with persistent cytopenia undergoes a very extensive panel in our center, and about 30% of them are diagnosed with some mutations, and many of them are cancer predisposition syndromes. Here, this is from the paper. This is a small table. You don't need to read it. You see all the mutations, but I want to talk about the pink mutation because to highlight another topic in precision medicine that is not often mentioned. And this is about GATA2 deficiency. So GATA2 deficiency is predisposing to AML. And this is a child, a 13-year-old child that came to us with aplastic anemia, typical aplastic anemia. That was preceded, however, before this with some neutropenia. There is no family history whatsoever. We just routinely, not expecting anything. Because most of the aplastic anemia are actually negative in the screen, we screened him and found germline GATA2 mutation. But then came the real tragic story, because when we sequenced all the family, what we found is we found a 7-year-old child with a 7-year-old child that carried a sister, 15-year-old that carried the mutation, and the father that carried the mutation. Now imagine the social impact, the psychosocial impact of such a diagnosis. So sometimes precision medicine, especially in pediatrics, can lead to devastating diagnosis that in this case it impacted all the family. The father stopped working. Now the children need a follow-up, etc. Really a catastrophe. So our diagnosis of also social consequences. And the very last slide that I'm going to show you is that part of a study that we are doing, and that we discovered mitochondrial abnormalities not only in the sick one but also in the carriers. And we think mitochondrial abnormalities are the earliest abnormalities that you can diagnose in GATA2 deficiency, and maybe they are targets for therapy. For sake of time, I want to continue with what I wanted to talk about, which is the incredible loss of life of children and adults that were massacred in the 7th of October, just 1 year ago, and the consequences of this that are still, terrible consequences of this that are still ongoing. Thank you very much.
Thank you, Professor, for your amazing talk. For the sake of time, there are short questions from me, definitely. Let's leave them for the Q&A session and move on. Our next speaker is Professor Gustaf Ljungman from Sweden. And he's the leading researcher at Uppsala University and also the co-chair of the Genome Medicine Sweden for Childhood Cancer Group. Professor Ljungman's talk today will be dedicated to the Genomic Medicine Sweden Childhood Cancer Project.
So thank you for the very kind invitation and introduction. I'll be talking about Genome Medicine Sweden, the Childhood Cancer Project. I can see that it came out a bit different than we thought, but you already introduced me. This is about a precision medicine project in Sweden. And if you can't hear me, just shout if I don't use the microphone in the correct way. The Childhood Cancer Project is part of a more comprehensive project, the Genome Medicine Sweden initiative, which is Sweden's ambition of national collaboration for genomic medicine. And it contains other nodes like adult oncology, adult hematology, microbiology, rare diseases, etc. But childhood cancer is a node of its own. And precision medicine is something you already know. Previously, we gave the same treatment to all. We still do that pretty much in oncology, but increasingly we try to find the right treatment for the right patient. And the aims of this project that we have in Sweden was to establish nationwide access to whole genome and transcriptome sequencing for pediatric cancer patients, with the intention to increase the diagnostic precision and refine risk stratification. Detect targets for precision cancer medicine, identify clinically relevant hereditary conditions associated with childhood cancer, establish national resource of DNA and RNA sequences for pediatric cancer research, a very important part of it, evaluate the future potential value of large-scale sequencing techniques for childhood cancer patients. We, of course, had challenges, as we always do when we go into new areas. We had no top-down steering. Sweden is a long country, a large country. It's more than 1,500 kilometers long, with 6 different pediatric oncology centers. One difficulty was to embrace the gray zone between clinics versus research, finding funding, etc. Expensive methods, methodological expertise required, skepticism among some oncologists and pathologists, so not everybody was on board when we started, and creation of regional teams and molecular tumor boards with representation, of course, from oncology, surgery, pathology, genetics, genomics, also bioinformaticians, of course, ethicists, lawyers were not in the molecular tumor boards, but part of the development of the project. So this is a picture of the sample and information flow, and if you look to the left, we have the patient that is going to be biopsied, and we inform the family, get most of the times consent that is very close to 100%, but not, some say no. And the tumor has to have a cell tumor content of more than 40% to proceed. Thereafter, DNA and RNA are prepared and sequenced, and we also, in addition, perform methylation arrays for brain tumors and some sarcomas. Bioinformatically filtered, and then the findings were discussed at molecular tumor boards, where we have the geneticists and we have the germline variants of clinical significance, which then indicates that we need genetic counseling, and there is a report with pathology for the findings. In addition, we want to have all the raw data for future research, and it's presently kept in the Swedish Childhood Tumor Biobank, but we plan to have a national data lake where this can be kept in addition. We published an article on the first 118 patients, the diagnostic yield from a nationwide implementation of precision medicine for all children with cancer. So this is it's about equity. We want all children in Sweden to have the same possibilities for diagnostics, but also for treatments. This was published last year in JCO Precision Oncology. And to summarize, if you look to the right, we had equal inclusion from all centers. We have proportional distribution of diagnosis, except for lymphomas. Hodgkin lymphomas, you know, have very low tumor content. Then also somatic genetic variants of clinical significance were found in 91% of the included cases, and potential drug targets in 24% of the included cases. Expected findings were mutations in ALK, NTRK, BRAF, FGFR1, etc. But there were also some surprising findings. We had a patient with a tumor mimicking rhabdomyosarcoma, but with complex fusion genes, including EWSR1, KLF15. And we know that this conventional chemotherapy is not effective, and this patient was treated with pazopanib, which is a pan-tyrosine kinase inhibitor. We had some unexpected findings. As I said, this was a rhabdomyosarcoma with an ERB2 amplification demonstrated by whole genome sequencing and then validated in different ways. Another example, infantile fibrosarcoma, was suspected but was revised as a rare genetic variant of synovial sarcoma after whole genome sequencing. So it makes a difference. We have some re-diagnostics done. One part of this project is also to look at the hereditary part and the germline. In the CHICAP project, the Childhood Cancer Predisposition Project, it was the flow was quite similar. We took blood samples for children with brain tumors and solid tumors, and a skin piece of skin where fibroblasts were grown for leukemias. And this was sequenced, and we found in a CHICAP clinical list 100, or we had 189 genes that we looked at, and we found there were positive CHICAP criteria for 194 in a group of 300 that were reported in a special paper, and this was then discussed at the molecular tumor board and published in a paper earlier this year in Lancet Regional Health Europe. There is also a published paper on the pediatric ALLs, where it was a feasibility study, and they could show that we found all important variants, but there are still some problems to get it in a timely manner because we need it quite early for the leukemias. So we're still at a point where we do both, which is expensive, but we want to move on. And now it has become part of the clinical work, and that will increase the possibilities to improve the situation. So highlights of operations from January 21st when we started. We have 559. This was when we stopped the project from being only a project when it became clinical as of 1st of May. 559 solid tumors, 200 leukemia sequenced, more than 600 germline genomes analyzed for actionable variants, 8.5 clinically relevant germline variants for all patients, higher, 11% for solid tumors, where only 4.5 was known before. Inclusion rate is around 80% for solid tumors and more than 90% for leukemias, and mainly low tumor content or not enough material. Results for the solid tumors were that 23 patients, 4% had a revision of morphological diagnosis after sequencing. At least 47 out of 528, around 10% of solid tumor patients had therapy modified because of the findings. 29 patients received a targeted drug. 1 patient was suspended from a targeted drug. 7 patients received immune checkpoint blockade. 11 patients received modified conventional treatment. So it made a difference. And data is being uploaded to the Swedish Childhood Tumor Biobank right now. It's a tumor, tissue, and data biobank. The mean turnaround time was below 3 weeks for most centers, but we still have challenges here. And it became part of routine publicly funded healthcare as of May 1st this year. And we don't have very much evidence for treatment, but we can lean a bit on the informed data where it's still, we still know that using single drugs is challenging, but for the patients with very high priority targets, there is a survival benefit of targeted treatment, and perhaps we need to find more different combinations, which is in line with our previous speaker showing that the treatment often works for a limited time, and then we find the tumor finds other ways. So we now are implementing this. It's important with equal or equitable implementation. important to keep up the unique population-based model which we have in Sweden. And as I said, it's publicly funded. We have remaining challenges. We need to get all the centers now, when it's done in the regions, to submit their genomic data to a research database, because this is very precious data. We can't do it at a second time for research purposes. And we further need to develop the molecular tumor boards. Further evaluation, including health technology assessment, is needed, but we have done rudimentary such models also. So conclusions are: clinically informative variants are found in most types of childhood cancer, where sequencing is performed, even in an unselected national cohort. And good results of embracing the gray zone between clinics and research. Clinicians, oncologists, pathologists must increasingly learn to use genomic information for diagnostic and treatment decisions. And this is just a case. Another case, it's a neuroblastoma, a patient with a neuroblastoma, left adrenal from the start. If you look at the next picture, well, this patient received conventional treatment, went into remission, but had a relapse, which you can see in the second picture. And it was in the thorax, paravertebrally, but also in the right groin. This patient had an ALK mutation and was put on lorlatinib, which we heard about previously also, and miraculously, after 8 weeks, there were no signs of the tumor anymore. And in addition to the treatment, we can also follow the risk of relapse with different markers. At the bottom there is the ALK mutation, but at the top chromogranin. So lots of collaborations. I want to acknowledge the chair of this cancer project of Gisselson Nord, but also Johanna Sandgren, who is here, was an ethical legal lead, and we had Josephine Palle representing leukemias and Anordring, the childhood cancer predisposition. And we were funded by the Swedish Childhood Cancer Foundation mainly, but also by the government in this endeavor. And my last picture, precision medicine is here to stay. Targeted therapy helps more children survive childhood cancer. The GMS childhood cancer gives all children in Sweden with cancer access to precision medicine through sequencing, whole genome and whole transcriptome sequencing, improved diagnostics, targeted therapy, and detection of cheek-up, which is not always only a pleasant thing, but often good to know anyway. And the picture to the right is from a paper, a boy with an ALK mutation who couldn't tolerate, he had a condition where he could, Fanconi anemia, where he couldn't tolerate conventional treatment. And he also had an ALK mutation, and 5 years later he's living, doing well. So thank you for your attention.
Thank you so much for your talk, and I invite you to the Q&A session at the end, and then let's have a further discussion on this. Our today's last talk will be video recorded, and it is about a very intriguing topic of liquid biopsies and how they can help in neuroblastoma to detect relapses earlier. And this talk will be given by Marie Bernkopf, who is the head of the laboratory at the Solid Cancer Center in St.Anna Children's Cancer Research Center in Austria.
So hello everyone from my side. It's a pleasure to present to you Mona Lisa, also on behalf of all the Mona Lisa partners, partners and colleagues working on this fantastic project. So Mona Lisa is a SciOpen pragmatic clinical trial to monitor neuroblastoma relapse with liquid biopsy sensitive analysis. And so a pragmatic clinical trial compares the efficacy of interventions And in this case, that would be diagnostic options in a real world, so in a real world clinical setting. And so Mona Lisa focuses on neuroblastoma, and as you might have already heard in the previous talks of this session, is neuroblastoma an embryonal tumor which arises of the sympathetic nervous system. The primary tumors most commonly occur in the adrenal gland. And so the scoring, so depending on if it's a low, intermediate, or high risk neuroblastoma, they depend on the clinical features, for example, age, and on the histology of the neuroblastoma, if it's differentiated or undifferentiated, and of the genetics. So if there are certain genetic alterations present, as for example, the MEGAN amplification, which is an oncogene. And in 90% of high-risk neuroblastoma, there is already a metastasis happening to the bone marrow. So there are tumor cells in circulation and then metastasize into the bone marrow, but also the liver, for example, and other organs. It's the most common solid tumor in infants, and it's about 1,500 patients per year in Europe newly diagnosed. And so besides the young age, there are also more clinical challenges. There's the 5-year survival rate of high-risk neuroblastoma being below 50%, which is rather low. And it accounts for 15% of cancer-related deaths in children. And despite the very intense treatment, more than 60% of the patients with high-risk neuroblastoma progress or relapse within a year. And patients who relapse have a very dismal outcome, with less than 10% being cured in the end. So there is an unmet clinical need. And so once the first line treatment is finished, further follow-up monitoring is done according to international standards by nuclear imaging or MRI, and also bone marrow aspiration every 3 to 6 months, which is invasive and burdensome, simply because those young children will not lay still in an MRI, so you need to give them anesthesia, for example, as well, and this is very burdensome for the patients, but obviously also for the families. Therefore, we need better, and with that we mean more sensitive, but also less invasive markers to monitor disease. And we would suggest, and we believe in liquid biopsy tests for doing so. And so what are liquid biopsies? So these are basically the tumor cells or parts of the tumor cells. So that could be certain protein, vesicles, cell-free DNA from the nucleus when the cell is basically degraded, that are released into the bloodstream and can also be found in other body liquids, for example, urine or CSF. And so those liquids can be with a very minimally invasive, for example, blood draw collected. And so these allows a very frequent sampling for disease monitoring, which is very crucial, especially also for young children. And we can then analyze this cell-free DNA that is in the plasma of the blood, and also the mRNAs that come from the tumor cells with very highly sensitive methods, and in combination with the frequent sampling, detect also relapse earlier. And this is what we did with the Mona Lisa partners together. We have shown in numerous previous publications and also joint projects that we can use liquid biopsies, and with that laid the foundation for innovative liquid biopsy studies in neuroblastoma. And so there are retrospective studies that have shown that we can detect with sensitive methods the tumor-derived circulating cell-free DNA and neuroblastoma-specific mRNA in plasma, and with that detect relapse earlier, and that up to 17 weeks before it's detected by imaging and also bone marrow assessment according to the international standards. In addition, we can also use liquid biopsies to identify clonal evolution, so different clones of the tumor cells, and also detect therapeutic targets, as for example, ALK mutations, because an ALK mutated tumor can be treated with very specific ALK inhibitors. And so that is an example of a patient from Vienna who had a MYC amplification and also an ALK mutation. And as you can see here at the very beginning, at the time of diagnosis, all the liquid biopsy markers are very high, and they drop sharply during the initial treatment, and then they rise again here for the first relapse, and then later in the second relapse, as you can appreciate here. And what you can also see here is that we see already a rise in the signal before the relapse is confirmed in the clinic. So for the first relapse, that's the case, and also for the second relapse, that was the case. And so that gave us also confidence to work further on liquid biopsies and see the potential also for other patients. What we also did is, all Mona Lisa partners, we have established workflows for sample shipment, for pre-analytics, and also analytical pipelines according to the EU in vitro diagnostic regulations that are in place since 2024, which was also a prerequisite for this call. So we have already defined in previous publications what the best pre-analytical conditions are for sample shipment, which temperatures, what should be the maximum duration, then how to process the samples, how to isolate the plasma, and then the RNA, mRNA, and the cell-free DNA of the plasma. And then also how to do the analysis. So there are the SciPen reference laboratories and Mona Lisa reference laboratories now that are also accredited and work according to EU IVDR, and with that send then the reports with the results back to the hospital. So that will be reported back to the hospital and the treating doctors. So the aims of this project are to, first of all, establish a pragmatic randomized clinical trial, and within that trial to monitor patients with relapsed neuroblastoma with this liquid biopsy tests, and also assess early molecular progression or relapse. What we will also do is we will support the trial by building a historical cohort of retrospective samples we have and analysis we have done with this liquid biopsy tests I've described. We will also develop databases and a digital decision support tool to help oncologists use the new monitoring and the liquid biopsy results and help them interpret them. And we will also assess patient-reported outcomes and quality of life measures as well. And this is basically an overall aim that we have, that the long-term objective for us is to establish liquid biopsies as a standard of care for patients with neuroblastoma. And so to start with the clinical trial, the primary objective there is to investigate whether liquid biopsies may detect imminent relapse or progression earlier through either a rising new liquid biopsy signal or an increase in signal. So these are both called molecular events now in our study. So it's either that the certain liquid biopsy markers are not detectable and then they build a new signal, or it's already detectable, but there is a rise in signal that is above a certain threshold we define in the lab. And so the inclusion criteria for the clinical trial are patients with high-risk neuroblastoma, diagnosed relapse, and at least a stable disease, and no active treatment trial at the moment. And we will randomize 150 patients into 2 arms. So you see here, arm B is the standard of care monitoring arm, where there is monitoring done in a standard way, which is mainly imaging every 6 months. And the arm B the arm A. The arm A is as well the standard of care monitoring every 6 months, but in addition, there will be a blood draw, so a blood samples for liquid biopsy testing every month as well. And so the recruitment will be for 3.5 years, and it should start end of 2024, beginning of 2025, and will be rolled out through 2025 then. We will report those liquid biopsy results in real time. And this brings us to the work we are currently doing to define what is actually a signal. And so this is for the reporting in arm A relevant. So we have, for example, no change in signal is no indication of an event. So just the advice would be continue monitoring. Then if there's a decrease in signal, same story, it would be just continue monitoring. But if there is an increase in the signal, or if there's a new signal we see with our lab tests, it would be an indication of a molecular event, and we would advise to perform disease assessment with, for example, imaging. And if the result is unclear in the lab, we would call it an inconclusive result and advise to repeat the blood draw and the sending of the blood tubes and the liquid biopsy tests, or wait for the next liquid biopsy sample, which will be in a month's time anyway. So this brings me to the liquid biopsy diagnostics. So here we aim in this work group, we aim to deliver the mRNA and cfDNA-based liquid biopsy assay results in real time to the trial. We will also implement quality measures and harmonize reporting of liquid biopsy in vitro diagnostics throughout the trial. So to harmonize also how all those different reference labs report their results. We will also roll out the liquid biopsy tests in the MONALEESA partner countries and provide training materials there. And we will also provide state-of-the-art bioinformatics and statistical data analysis. So this is what I already mentioned. We will also build a historical cohort to provide this additional statistical power to the prospectively generated data set within the clinical trial, and we will correlate the existing blood-based cfDNA and mRNA results with the clinical disease course. And I've already showed you a patient from Vienna, so this will be a patient from Berlin from this retrospective analysis that will be part of the historical cohort. And here you see as well the rise in signal here in green, already much earlier than the clinical relapse that was then diagnosed later during the course when the signal was already quite high. So this is work by Haley Deutzer, who is also leading that work package. And this is also work from her group and Lodrini that I'm showing here. Then we will also develop a service to support clinical decision making based on liquid biopsy data. So that's very important, I think, as well. So we will co-design the tested and validate this decision support tool based on the liquid biopsy analysis. We will also collect, manage, and provide the trial data in those different databases we have that are known in the pediatric oncology field. We will also visualize the output of the sequential liquid biopsy analysis in, for example, R2. This is this data visualization program. And the data will be collected in the ZIPO and RNet, the bioportal that is quite known in the neuroblastoma field. What I think is a very crucial part of the MONALEESA project is to assess the patient-reported outcomes, the quality of life, and the patient advocacy aspects. And for that, we will assess the quality of life, patient-reported outcomes, and also the symptoms with questionnaires and standardized assessment tools. You can see here a snapshot of it. And we will do this electronically by the parents using a smartphone app that will be developed or specifically also for MONALEESA and what is needed there. And this brings me already to the summary. I hope I could make you excited about the Mona Lisa project, which is the first trial prospectively evaluating liquid biopsies in pediatric cancer, and also the first that will base clinical decision making in real time on liquid biopsies. And so in that trial, we will randomize 150 patients with relapse into standard follow-up, mainly by imaging, whereas a standard follow-up plus monthly liquid biopsy testing from blood samples. Those blood samples will be analyzed in the liquid biopsy reference labs that work according to EU IVDR. And those tests we have already established will be, on the one hand, analyzing adrenergic mRNA, so neuroblastoma-specific mRNA, and also cell-free DNA, where we will look into ALK mutations, ALK amplifications, MYC amplification, and we will also run a gene panel. And with that, we will hopefully detect minimal residual disease and also a change in signal or values, and also hopefully detect therapeutic targets. In addition to that, we will also develop clinical decision support tools and also quality of life reporting app, and feed all the data we will generate into BioPortal and also links to trial databases. And with that, advance digital tools as well. And so these are all the Mona Lisa partners. Everyone is super excited about the project and bringing liquid biopsies really into clinical practice. Here you see all the partners that are in total 25 partners in 11 countries. This is the coordination team, project coordination by SciOp, the scientific coordination from the Lieve Titkat from Princess Maxima Center, and Sabine Taschner-Mandl from the St.Anna Children's Cancer Research Institute in Vienna, where there is also the project management. And I would really like to thank everyone being involved. It's a great project to work on, and I hope I could share my excitement about it with you for this project and liquid biopsies in general. And I'm looking forward to your questions, which I will unfortunately not be able to answer now here in the Q&A session here, but I will be hopefully right now in an airplane to Riga, and then I will join for lunch and the rest of the day and tomorrow. And please approach me with all the questions you have about Mona Lisa, especially the technical part as well, which I skipped here a bit. Please just come and see me, and yeah, see you later then. Bye-bye.
Now we have a really good half hour for questions, and I want to invite our today's speakers who are here to these nice chairs, and I hope now no one has forgotten their questions. No, I really would like to kindly invite you to ask the questions that you had.
So, nice talk by three speakers who are present here. So one aspect which was very common to all three of you is hereditary aspects, mutations or similar events, at least in some subgroup of patients. So have you ever thought about some of the viruses which are genetically inherited as well as integrated into our chromosomes, telomeric regions, or their presence and deactivation affecting certain genes which can also cause tumor? Because all of you are involved in sequencing, and which is a wide resource you have already with you, where you can look into this presence of these viruses. Have you ever thought about it, or do you have any data?
So we have looked into this, and I think that there was also a dedicated effort by the global cancer genome sequencing people. And to the best of my knowledge, at least in the cohorts that we have been involved in pediatric cohorts, this was very systematically screened for viruses and bacteria and parasites. And so far there was nothing that could convincingly be associated with pathogenesis. So there was no difference, for instance, between tumor and normal cells from the same patients and so on. So you could obviously argue maybe this is, a carrier of a virus that is infecting different cell types. But at least to the best of my knowledge, there was no causative link identified between any pathogens and pediatric cancer.
The only thing that comes to my mind is that there is a study from Sloan Kettering. The name of the investigator, who is a good friend of mine, is running. I cannot say it now. That shows the transposable elements, which is ancient viruses, right? Plays a role in activation of various oncogenes in pediatric solid tumors, or in general, for example, MOAB. So that's the only thing that I can seem to remember.
Good morning. I'm Tony Andreu, the Scientific Director of Pediatrics, the European Infrastructure for Translational Medicine. Thank you for these exciting presentations. And I would like to ask you about your vision, the future development of our understanding of molecular biology in the development of real precision medicine, because I think obviously the development of genomic initiatives like the one that Professor Ljungman has presented has represented a big step forward. But if we want to better understand the phenotypic presentations of mutations that are cause of cancer, we need to understand a more complex scenario of the multiomic reality. And I think we need to take one step forward in establishing strong collaborative efforts between genomic sciences, proteomic, transcriptomic, and other omic technologies. I think we cannot restrict personalized medicine to the concept of genomic medicine, and we have the opportunity of moving forward. So my question is, how is your vision about how to unlock the possibility of complementing the different scientific and technical expertise which is required in the community for having a more precise understanding of the molecular reality of the phenotypic presentation of cancers? Thank you.
I can comment from the Swedish part that this is a very important and actual issue that is being discussed, and we look at creating there is a new project that is coming up called the Brainchild, where different layers of data will be brought together with a phenotypic information from the registries together with the genomic data, and also digital pathology, for example, could be collected. So this is all in the spirit of making future progress more accessible for researchers to more easily combine, for example, an application for research to gain all these different types of information, to combine them, and also using artificial intelligence to be able to process it, because it's a lot of information. That's in short. I also think we need to proceed with proteomics and metabolomics, and this is a changing field all the time, I think. So thank you.
Yeah, I mean, ironically, for whatever reason, precision medicine is always associated to targeted therapies, which I think doesn't make any sense conceptually. I mean, precision medicine means that you try to identify the best treatment for an individual patient or for a cohort of patients that share molecular similarities. but it's there's kind of this dichotomy of people only looking into cell intrinsic and people looking into cell extrinsic mechanisms, and obviously they all belong together. And it's not only about adding more omics layers, but also about getting more idea of microenvironment, and not only the immune microenvironment, but also other cell types. When thinking about brain tumors, it's also about cell-cell interactions between neurons and glia cells with tumors, for instance, which is not at all related to the immune system in this case. But it's also about systematically capturing other readouts like imaging data and surgical data and whatever else can be captured that can be brought into a better understanding. And I think one of the efforts that we are currently making between all the precision oncology programs in Europe is actually harmonizing the data and also trying to come up with federated approaches to give algorithms access to the data, and this data explicitly is not restricted to genomic data by any means.
Lars Baumbusch, Oslo University Hospital. I liked your idea about the newborn screening. I mean, it's even if there is no much evidence so far, we have these wonderful collections of the filter cards and the registries. I would like to hear more. What are you thinking about genome sequencing, transcriptome, or what else? What should we do with the blood spots? How to analyze them in the future?
Well, this has two different aspects. So one of them, and this is also starting now in different places, is actually what is called the genetic newborn screening, right? To not restrict it to metabolic screening, but also think of other Mendelian diseases that can potentially be detected early on. And our human genetics colleagues are currently starting a project where they will screen the 3,000 newborns that are successively coming to our birth clinics in Heidelberg, actually for this reason, in parallel to the metabolic screening. And then there is the other potential for screening that I was referring to is basically looking at circulating DNA or potentially also circulating cells at some stage, which obviously is much more experimental at this stage. But we have evidence that from one dry blood spot we can extract enough circulating DNA, whatever that is, that would be sufficient, for instance, to run some of the tests that Shai was referring to, so where we can read out copy number and methylation, for instance, from one dry blood spot that has been hanging around in a repository for 5 or 10 years, which I think is kind of technically at least a promising next step.
I think we have room for one more question. Please.
Yeah, so thank you for some great talks. I'm Torben Mikkelsen from Aarhus in Denmark. So your projects in Sweden and Heidelberg is very great and extensive, and you have a lot of patients, but still you have very rare diseases. So are you able to share the data with other countries and other research projects now that the data have been generated and the patients, I guess, have given consent for obtaining the material for the biobank?
I can start if you like. So we have received 10 million worth of funding to actually do exactly this, to basically bring together all the different larger European programs on cancer genome sequencing in children. Where we think that even for the retrospective cohorts, we will get to 6,000 or 7,000 patients with available genome or exome and RNA sequencing and mostly methylation analysis. And prospectively, this would be like 1,000, 1,500 patients a year across Europe. And we have also started, and we have currently submitted a grant together also with the Swedish colleagues and the Latvian colleagues and others that have started a little bit after this first wave of precision oncology programs in France and Germany and the Netherlands and Denmark and so on, and the UK, to also get a part of this. And we think that the best way of doing it is actually to try and harmonize the processes as much as possible, but then really send algorithms to the data rather than having to move all of the huge data sets into one place, which we think is feasible now. And yeah, we have the first evidence that is working, and have started the project to do exactly that, and to also make it public facing, like that other people can use it. We also are thinking of an interface towards industry, because this is a recurrent request that we get for target patterns and frequencies and so on, which could be one way of making something like this sustainable. Because then, if you could charge industry and not charge academia, when they request data access, then you could use this to be maintained for the database or for the infrastructure to be maintained. That's the idea.
I can just agree and stress that we know that it's not enough just to do it on a national basis. We need to collaborate. We talked about that yesterday also. So collaboration is the only way forward, and in different ways we need to find the ways to do that, and that is increasingly done. So good. Thank you.
And maybe as a last comment, it's so being a small country as Denmark and maybe the Baltic countries, we definitely want to participate in giving data, but perhaps also doing some of the research. So it's really important, I think, to be part of this collaboration as small countries as well. So.
If I may, I have a question for Shai, because in your first example where you showed this CHUK mutations in the leukemia, do you know whether this is selection or de novo acquisition of these mutations, of these RAS mutations?
It's actually selection. I mean, if you look very carefully, and I think this is the general theme, if you look very carefully, very sensitive, you identify them in the beginning. I have maybe a question to you also. If you have anything to thought, this is something that troubles me. I'm thinking about all the time. I can't, why do we have subclones? So why do they, if a cell starts and it divides a little bit faster than another cell because it acquired a RAS mutation, what we should see is this becoming clonal. But what we actually see are subclones that quite often even remain very stable along the disease in different environments, suggesting that maybe they benefit from each other. So I just wonder what you think, and if there is any evidence to support it.
Well, I think the simplistic answer to this is that any cancer is an organ rather than an outgrowth of one cell type. And they try to be diverse, to be resistant or resilient against different threats, right? And we have also seen that in neuronal brain tumors that some tumor cells, which are clearly tumor cells, actually show glial differentiation. Why would they do that? Because it's a tissue and it's not an outgrowth of a single cell type, which would probably be very weak to resist everything.
I also think, how can we model it? But this is it's not about an individual. It's a village. It takes we once wrote an editorial. It takes a village to grow leukemia. It takes a village to grow cancer. And that's also relevant to the question that were asked from behind here. It's not about genomics or proteomics. It's about the complex interaction between the cancer and the body where it is.
Gentlemen, I need to
Sorry,
stop
Anna,
you. Thank you.
We just hijacked the time here.
I completely understand. It is absolutely enjoyable, and thank you again for your wonderful talks, and one round of applause again for you.